All right, let's get started. Welcome everyone to our second session of our webinar series on foundations of colorectal cancer screening and care for health educators and community health workers. On today's session, we will be focusing on case-based management and care delivery in medically underserved populations. This is just a kind reminder to everybody before we continue that all participants are muted upon entry. Please make sure you engage in the chat if you have any questions or anything you would like to share with us during today's session. We also highly encourage to please participate during our case study sections. We will be asking some questions to the audience just to make the webinar a little bit more interactive for everybody. Also, please raise your virtual hand if you would like your line to also be unmuted. This meeting is also being recorded, and the slides and recorded link will be sent via email after today's session. Again, this is just a quick overview about our speaker for today, Dr. Kevin Lombardi. He's our Director of Research, Policy, and Health Promotion. His full description will be provided in the slides for your own time to review as well. And then for today, we are also the co-moderators here. My name is Frida Pineda, and I am the TTA Manager at NCHPH. And with me, I also have our Health Communications and Research Analyst, Ola Jamoke Oladipo, who is also handling the logistics for today's webinar. And without further ado, we'll pass it on to Dr. Kevin Lombardi to get us started with today's presentation.
Awesome. All right, let's get started, guys. Welcome, everyone. Remind me where you come from, who you serve, and how you serve them. Jump in the chat. I know we've got folks from around the country doing various things, but please refresh my memory so I can ground my lecture in the realities of your position and who you serve, how you serve them. What I want to do today is kind of quickly review what we spoke about last time, the pathophysiology of colorectal cancer, how it develops, to get an understanding of how we intervene and why we intervene. We are going to pick up our case study and continue and complete that. We're going to find that we have a patient that is not seeing his primary care as often as he should. He has multiple risk factors, and he is very resistant to the idea of screening, and we're going to have to convince him. We're then going to look specifically at community health worker interventions. Now, I chose community health workers for this because there's a lot of research and data on their interventions and what specific things work that they do. These elements are not necessarily limited to community health workers. They are used by everyone who talks to patients about screening colorectal cancer. We will go through that and look at the specific things we can do and say to increase the rates of colorectal cancer screening in resistant patients. And we are not just going to do that from the perspective of my opinion. We're going to do that from the perspective of data of what has been shown to work. So let's start with let's go. What's the next slide? Let's see it. So we'll start with pathophysiology. You'll remember this, and I gave sort of a long lecture on this of how mutations accumulate in the colorectal parenchyma over a lifetime, how those lead to the development of colorectal cancer. And to just sort of reconceptualize that very quickly is you start your life in and 99.99% of the time individuals start their life with very healthy epithelium in their colon. Uh, and what causes colorectal cancer is not just one mutation, it's not just two mutations, it is the accumulation of mutations over a lifetime. Now, in most individuals, and when that damage is in specific areas of the DNA, parts of the DNA that control the replication of the cell, parts of the DNA that control the cell's ability to recruit blood vessels and blood supply, and genes that are related to the cell's adherence to other cells in the area. Well, the system breaks down, and metastases and carcinoma can result. So, sort of that's the progression of how this pathophysiologically advances in most cases. Next slide, please. The screening recommendations I won't spend any extra time on. We went over them last time, but they are here for your reference. Next slide, please. And sort of what this stuff looks like, right? When you look at if you go into a patient's record and you find their last colonoscopy, you'll find these images literally there. You can take a look at them, and you can see both the screenshots from the exam itself, and they'll have like a pathology report or as well. So just to sort of briefly go over this, these are irregular findings. You can see, and in particular A and B, you have the polyps. And these polyps, you can see, have those vessels spidering throughout them. Those are cells that have garnered the ability to recruit blood vessels. They do that chemically. VEGF is a chemical signal that they can throw out, and that helps them recruit those vessels. As those vessels grow, you're one step closer to metastases. If those cells in those polyps lose the ability to adhere to each other, and there are these linkages that keep cells together, like keys, like if you have like Legos almost. If those go away, then those cells can come out of that polyp, go into the blood, and end up anywhere. Uh, as far as the constellation of where metastases tend to grow after from the colon, they tend to be downstream. From directly downstream from where the cancer is, they will go first to the local lymph nodes, in the mesentery, then, which is the area around the colon in the digestive system, the sort of sac of fat and blood vessels and lymph nodes that are in that area, and then they will drain to the liver. And from down there, from downstream from there, we have the lung and the brain. Those are the areas where the metastases are most likely to land, and those are areas where metastases, once they land, can grow very quickly. Why? Because the liver, the lungs, and the brain, they get a lot of blood. So when the if a it, all it takes is one cell to move down and settle to the liver, move down and settle to the lung, move down and settle to the brain, and that can lead to a whole tumor growing. And when you actually look at these things on, like, if you look at the organ or if you look on the imaging, it almost looks like a shotgun blast when you see the metastases, because they are just spidered all over the place. Why? Because it wasn't just one cell that landed over time, it was many that landed in different places. And those little metastases, those little tumors that you see, are the results of just one or a couple of cells that have colonized those areas. So that is why we do these exams, because when you do the when you do the colonoscopy, you can visualize these things and see how advanced they are. You can take those polyps and you can do pathology on them, and you can see what mutations have been done, and you can get a lot of information about the patient's risk, and you can stop that risk. Now, as you all know, there are new modalities that allow us to, in a less invasive way, screen for colorectal cancer. Blood tests now, fecal blood tests as well. If those are positive, we end up here anyway. The gold standard is the colonoscopy, because it provides so much more data. And it also has fewer false negatives. Now, no screening test is perfect. There are false positives and there are false negatives in any screening test you create. There is no perfect screening test. But the colonoscopy is the gold standard because it has fewer of those false negatives. A blood test or a fecal blood test is much more likely to give a false negative result. So this is where we want to move the patients towards, in particular, the patients that have higher risk factors, such as first degree relatives that had colorectal cancer before age 50. That's a big one. Next slide. And here's what the healthy stuff looks like. Again, no tumors, no irregularity, very smooth, very consistent, and blood vessels are smooth and consistent as well. This is what it looks like. And next after this, actually. No, I was actually done, believe it or not. You're in my head, Fide. Next slide, please.
Sorry, it's just that the slides keep changing on by themselves, so it's too late for me to change that
I feel like I'm on
that
a
option.
treadmill over here. Next slide, please. The risk the algorithm here, I won't go over this, but the key elements that make us determine whether a person needs screening before age 50 is that positive family history, and in particular, two or more first degree relatives affected is the big one. Float on that for a little while. Fide, I often hear about individuals, they're worried about cancer because they, quote, have a family history of cancer. And I'd say about 95% of the time I have a conversation with someone about that, they don't have a family history of cancer. And the reason is the way individuals in the general public define a family risk of cancer and how it is medically defined and how the risk actually translate to a real risk of you getting cancer are very different things. And I want everyone to remember this. An example is a individual who has, say, a who is concerned about having ovarian cancer. I was having a conversation with this individual who is not hypothetical; they are real. And she was talking about her recent exam and how upset and how scared she was about getting this exam to assess her risk for this. I asked her why she was concerned, and she said, "I have a family history of cancer, and I'm concerned that I have a higher risk because of that." And I said, "Well, what kind of cancers run in your family?" And she's like, "There's been two people that have had cancer, my grandmother and my aunt, or my grandmother and my cousin. One had melanoma, and the other one had throat cancer. And I'm very concerned about ovarian cancer because of a polyp." And I said, it's good that you're taking this serious. First of all, very good that you're taking your screening seriously. Good that you're assessing this polyp. But these cancers are not connected in a pathological way. Typically, when we're talking about colorectal cancer, uterine cancer, breast cancer, and we're talking about family history, first of all, it's two first degree relatives. Things like cousins, second cousins, these don't translate to that risk. Also, we ask these because we're concerned about, in particular, familial conditions. Things like in breast cancer, BRCA1 and BRCA2 mutations. Things like familial colorectal cancer or familial GU cancers for women. When you have someone who has a couple of deaths of cancer in their family history, but they are very different cancers and they are not first degree relatives, that does not translate to a higher risk, period. So it's important to have these conversations with individuals because they can scare themselves, and that can be motivating, but it also can be destabilizing to their lives. So it's important to have those. That we ask that for a very real reason, and we're really looking for familial conditions or familial risk. And these can be just genetic and non-genetic. A lot of it can be dietary as well. People in the family, in same families, tend to have similar diets as well and exposure. So wanted to make sure that be clear about that because that comes up very often. Next slide, please. Some research, we're going to breeze through this. Next slide, went through this last time. Uh, the ne to where they have the circles. I think it's the next one. Yeah, this is from a study I did on HRSA's Health Center Patient Survey. I looked at people all over the country, and it is I took the questions that looked at if they've gotten their colorectal cancer screening, why did they get it? If they haven't gotten it, why haven't they got it? And the surprises here is that most individuals at federally qualified health centers who have not have received their colorectal cancer screening have not received it because they either did not think about it or did not know they needed the test. Now, think about that for a second. Does that mean that those individuals were not told that they needed the test? No. That does not mean that. That does not mean that the conversation is not happening at federally qualified health centers. It does not mean we're not doing our jobs. It means those individuals didn't know. A lot of things come at folks when they're in the exam room. A lot of things. A lot of words they don't know. Half of it's Latin. It's technical. Uh, it's hard for folks to really remember everything and follow all that guidance. Even if we're having the conversations with them intermittently, it might not seep through. So this tells us that we need to change the way we're having these conversations. We need to bring in more channels. So not just the conversation in the clinic, but conversations with, say, non-clinical individuals that are associated with case management, for example, and not just conversations, emails, patient portals, mail them something if you need to. These are all ways to increase screening. And hey, let's remember, we're all living our value-based care world in our value-based care lives now. Uh, when your patients receive screening, they are less likely to need to go to the emergency room. They're less likely to have a late stage diagnosis, and that lowers the cost of care in your patient population. That's good for your patients for obvious reasons, but it's good for your health system as health center as well because it lowers that cost of care. Now, the way that translates to what that does is it increases the financial health of your institution as well through Medicaid awards. Through reimbursement levels, through lower penalties, these are all things that are very financially real for federally qualified health centers. And when you make sure your individuals get their screening, and you invest in those extra channels of communication, there's a good ROI on that, a very good
Very good
ROI.
ROI.
So we're not just throwing money into the air here. This is stuff that both helps the patient population and helps the health center in a financial and fiduciary way as well. So wanted to make that clear. Next slide, please.
We have a question from a participant in the chat, and it says, if there is no family history of cancer, do you think it's good to do a colonoscopy or the Cologuard is best? Especially in male patients, they say they don't want to have a colonoscopy.
Okay, so you're talking about just your average patient, no family history, says within the screening age, comes in, you're having the conversation. Uh, One, I always start with the colonoscopy and I tell them exactly what I told you. This is the gold standard. If we're going to catch something, we're most likely to catch it with this. And if we need to intervene, we can do it there. And it gives you, the patient, the peace of mind of knowing that you don't need to do that for years. Uh, Start with that. If the patient continues to be resistant to that, and you are concerned they're not going to follow through, that's when the conversation about the Cologuard or the blood test happens. That's how I do that. I don't start with the non-invasive, the Cologuard. I don't start with that conversation because I want to maximize the number of people who get the colonoscopy, who qualify for the colonoscopy, just because one, the patient, to my own conscience. If you do 1,000 of these things, 1,000 of your patients get a colonoscopy, or 1,000 of your patients uh, get a Cologuard, and that's how much you can do in a career. It might even only be 10 years you go through patients like that, right? 1,000 of them. If you're all those patients are getting colonoscopies versus all of those are getting Cologuards, well, there's about a handful of patients that had false negatives if everyone's doing a Cologuard. That's a handful of patients that didn't get diagnosed because you didn't push the colonoscopy. So for your own conscience, I do that because you're going to think about that. If you're a statistical or a mathematical thinker, you're going to think about that. And also, you're lowering the chance that there's going to be that false negative result, which, and like the Cologuard is good. I think the sensitivity is like 92%. But when we're looking at the colonoscopy, it's like 97%. And that's only a handful of percents, but it does make a difference. So one, the most important thing is get the patient to do it, but start the conversation with the colonoscopy. If they don't want to get it or they're not going to get it, they're not going to lie to you about that. They're going to be very, very upfront about but take the opportunity to educate them that that's the better test. Now, if this was the same person and they had a family history of early stage colon cancer, well, that's a different conversation. But it seems from your comment that you understand that very well. That's a different conversation. We really want to push the colonoscopy for those patients because that false negative result chance goes up for those. So let's just go and take a look at Mr. Rossi. We're gonna kind of go through where I can't remember the exact slide where we stopped, but I'm gonna go through, do a read of this, and then we're gonna start the way we were last time, is really picking this apart. So I'm going to read the case. 57-year-old man. He presents for a wellness exam at his health center. He has a past medical history of hypertension and high cholesterol. Past medical records indicate that Mr. Rossi has a history of missing his appointments, poor compliance with his medication, and switching doctors. He has been unhoused in the past, and his current housing status is unknown. His record also notes that his stated reason for his appointment today is to refill his blood pressure medication. He undergoes a standard intake, including vitals and health-related needs screener. The results are as follows. When I see this patient, here are the things. Poor compliance. Well, that's kind of a judgy term that we used. I put it there for a reason. I don't like poor compliance. A lot of reason people don't show up. Uh, and this individual seems like he has some social and housing issues, right? When I look at his blood pressure, I see that the blood pressure has jumped significantly since we last saw him. But hey, that was 4 years ago, so a lot can happen. So I'm immediately concerned about, one, is he taking his medication? And two, is that medication appropriate, or we need to add a second line medication to that? The other thing that really pops up here is his weight. He's 145 pounds here, and he was 210 in 2022. That's a huge change. When you see a weight drop like that, your differential diagnosis or your concern, cancer, should be up there, right? Even if he looks buff, like he's been doing triathlons or whatever, I don't care. You see a number drop like that, the red flag's in the air, right? So those are the things that I'm concerned about. He only has two medications there, something for his blood pressure, something for his depression. So there's a lot we can do here. Next slide. We get this is where we left off here. So we went through this, and then I think we commented on it, and that was it. So we do the non-medical needs questionnaire. Uh, And I'm going to first talk a little bit about these. It takes forever to ask these questions in the exam room. Embedding these into your EHR, having the patient, or even printing them out and having the patient do them at intake and handing them to the provider, cuts a ton of time off of the interview and allows us to get a lot of really important collateral really quickly. It is rare when a patient's medical circumstances, in particular related to chronic disease, are not in some way connected to their lifestyle, social needs, or stressors in the home and so forth. So this is information you can get really quick and it's comprehensive. Down the left is a link to this particular survey. It's the WellRx survey. It's one that you can add questions to that are, say, particular to your area of the country and so forth. We all have different patient populations with different needs. But looking at the yeses here, the patient is skipping meals because they are concerned about food. They are concerned about homelessness. They are having trouble paying their utilities. They are having trouble finding a ride. Well, it makes sense why he's not showing up, right? No issue with childcare. Next slide. He is unemployed, does need help finding a better job, does not does feel unsafe in his daily life. Well, we're going to need to follow up with that. But no issues regarding threatening or someone threatening him at home or abusing him. Next slide, please. So this is where we start off today. Okay. Mr. Thomas is treated by his provider.
Sorry, just a little note here. I would like to highlight that there's an error in this slide. It's supposed to be Mr. Rossi. I made this correction earlier, but I don't know why it's here again. But I will be providing the updated slide to everybody in the
You know what?
follow-up email.
I was concerned you weren't paying attention, Fide, so I changed the names on
Yeah.
you. So Mr. Rossi is now Mr. Thompson. Excuse
Yeah. Yes.
My bad. There's Fide taking the fall for me again. She's a good soldier. Mr. Rossi Thomas, the patient, is treated by his provider. Upon physical examination, he's noted to be withdrawn and to exhibit closed body language. You know, when they sit like this. His responses are terse, meaning quick to the point, and he seems irritated. He's got a mood. His physical examination is notable for posturing, like this, hands on the knees and forward, reduced reflexes, and weakened gait. When you do the reflexes, he's not his response is weak, as in like his knees not going out as much, and his gait is weak. So when he's walking, it looks like he's having trouble, say, extending his feet the whole time. He's noted to be thin in appearance. So the weight gain, it's not related to the triathlon. He literally generally looks thin and cachectic, so he is losing muscle mass. He is losing fat as well. He's losing everything. Um, uh, we question him about his results, and we get the following details. And I'm going to read through these, and I'm going to ask everyone their opinion here. Um, Mr. Thompson worked as a welder until 3 months ago, and he was laid off. He has 2 months of unemployment available left. His truck is unreliable. He uses Uber and walks for transportation. Mr. Thompson has a family history of colorectal cancer, brother and paternal grandfather. Mr. Thompson has never been screened for colorectal cancer. His stated reasons are, I didn't know, and when questioned further, said, I forgot. Mr. Thompson has been taking a half dose of his prescription medication because he can no longer afford the medication. And Mr. Rossi, I think, is has been intermittently homeless since last month. When he lost his HUD-supported housing due to non-payment. That's a big deal. He has been living with relatives since then. That is still homelessness. When asked about his changes in weight and strength since his last visit, he attributes it to stress. Common response. Okay, what do we think? What are the we've got a lot of red flags here, but what grabs your attention of things that in particular are in need of immediate attention with this patient? Someone mentioned family history. Lydia, are you able to join us? Because I don't know, family history, make an argument. Why does this matter? Brother, paternal grandfather, is that important? You're muted if you're unaware. Well, um, here's the thing you caught. That's two. And those are within the requirements of how close the relatives need to be related. We've got paternal grandfather and we've got brother. Those are first degree relatives. That means that this individual is statistically. Oh, Lydia, are you able to join us?
Yes. Can you hear me
First,
now?
yeah, I can. I'd love to know who you serve and how you serve them. And I'm not convinced. I'd like you to convince me.
So I was referring to the fact that he had his brother and his paternal grandfather had a colorectal cancer. So that's why I mentioned that it's a family history. So it's something that
Yes,
goes into his family.
100%. And can you tell us who you serve and how you serve them?
So I'm the refugee care coordinator and I work at Community of Hope.
Well, that's very interesting because you may be seeing quite a few patients that have never had colorectal cancer screening because of the regions of the world they come from. Am I correct
Correct.
in saying that?
Yeah, you're
Ah,
right. Yeah.
very interesting. Well, I'd say for your patient population, this is particularly important because you may be seeing people in their 50s and 60s who have never had this. Thank you for sharing that and for doing what you do. But
Thank you.
if this said cousin and brother, I wouldn't be as concerned. It says brother and paternal grandfather. And the things that I want to know is one, how old did they have that cancer? I want to follow up question. And what was the result of that? When we see those single folks within the direct family line that are having cancer, the same type of cancer, we start to get concerned that either one, there may be a genetic issue, there are family conditions that make colorectal cancer much more likely to happen, and two, it could be social and cultural as well. Folks from similar families tend to have folks from family folks in a single family tend to have similar exposures, occupational exposures, stress exposures, and dietary exposures. And remember, inflammation is the main driver that sends that very nice, clean, and a healthy parenchyma into benign and then metastatic growth. So 100%. Any other red flags here with this individual?
Kevin, before you continue, we had a comment from Marjorie Hardy.
Do
Uh,
we?
yes, it's in the Q&A. She mentioned that her mother has colon cancer and her diet consists mostly of bread and cheese, and her diet is different, which is mostly vegetables. She's had a colonoscopy but prefers the non-invasive testing. Do you think her probability of getting colon cancer decreases due to her diet? And she frequently gets the Cologuard screenings with negative results.
I'm not seeing that. Why I'm looking at the chat. Am I looking in the wrong
Oh
spot?
no, the Q&A.
Where's that?
Oh, do you not see it? 1 second.
I'd like to take a look at that.
I can copy it and put it into the chat.
Please do. Please do.
Mhm.
Okay. Mother had colon cancer. Her diet consisted mostly of breads and cheese. I'm a big fan of breads and cheese, by the way. Mostly vegetables. I've had a colonoscopy, but prefer non-invasive testing. Getting colon decreased due to my diet. Okay, so yes, 100%. I mentioned this last time, but not this time. But the thing that drives mutation is inflammation, and inflammation there are these is driven by free radicals, and these are on a chemical level, on a microscopic chemical level, these mutate DNA. Now, when you eat a lot of fruits and vegetables, and though the chemicals in the vegetables and the fruits, in particular things like antioxidants, vitamin C is a big one. They balance out those free radicals and sort of act like a shield, right? And all this stuff mixes together in your colon. So if you take the same individual and they are eating bread and cheese only, or a different individual is eating vegetables, fruits regularly, they have a significantly lower chance. Now, everyone is different, and sometimes there are just flukes. This isn't determinate. But if you get 100 people on one level that just eat bread and cheese, and you get 100 people who are eating a lot of fruits and vegetables, you're going to see fewer cases of cancer on this side. That's just the truth. What I would say is if you are concerned about it, get the colonoscopy. But for someone who has a good diet, who has some family history, but not enough to be at higher risk, and who is doing their non-invasive testing on time, you are checking all of your boxes, and I wouldn't have any extra concern. What I'd say is continue with your screening and most importantly, continue with your good diet, and that goes for everyone. And I will say that another thing that lowers inflammation that folks forget about is exercise. Get out there, go for a jog. It lowers your inflammation burden for hours afterwards. A walk works too. Can we go back? I think I missed something. Unless that's your way of nudging me forward. Um, uh, yeah, so the medications, you got it, because his blood pressure went up, right? From 128 to 178 is not a small thing, and that's not just in the exam room. You're experiencing 30% more pressure in your blood all day, every day for 4 years. That leads to breakdown of systems. That leads to pressure on the heart. That is chronic disease. So 100%. This individual needs to be first. He needs to be on his therapy. So I'd adjust him back to his like his normal prescribed therapy, and then I'd want to see him in a few weeks and see if we need to add a second line. Um, don't miss the blood pressure just because you're concerned about one thing. There's more than one thing going on, right? Um, so 100%. Yes, 100%. Okay, so you nailed a big one here. Sarah, where's the Cologuard gonna go, right? This individual is unhoused. We're going to need to pull in our colleagues from case management, our CHWs, to find out, is there a consistent place where he's staying? Is there a place where we can get it mailed and really coordinate that 100%. 100%. The unhoused issue makes this way harder. When someone's unhoused, everything in primary care gets more difficult. Um, so, and again, the guy lost a lot of weight, right? We're looking talking about 50 pounds. It's over 4 years, but he's really unaware of this. Um, uh, it's so when I look at this individual as well, and I see that he's not walking very well, and he got laid off from a very physical job, these things are related too. A couple of things about the physical exam that's notable. The posturing, reduced reflex, and weakened gait are all signs of nerve impingement or neural issues that are risk factors for cancer as well. So reduced reflexes and weakened gait, I'm concerned about that. Seeing those puts cancer up on the differential for me. Next slide, please. Okay, we're back. He's Mr. Rossi again. So Mr. Rossi seems eager to leave the room after hearing the word cancer. He already didn't want to be there, right? You can tell by his body language. You say cancer, he's ready to jet. He gets, you say cancer, he looks eager to get out of the room. One, what are your next steps? Two, what do you guys do where you work with people like this? Do you have systems for identifying follow-up and socially supporting Mr. Thompson? Oh, Mr. Rossi. Well, I was a mess with the names with this one, Fide. The patient. Uh,
Sorry, I tried and I have
No, no, we both
fixation.
we both missed this one, but I'm the one that wrote the slides. The patient. What are we gonna do when he wants to leave the room? We need to do something, or we're just gonna let him walk out. And what do you guys do where you work? Take a minute, pop something into the slide, into the chat. Let me know your thoughts. So I'll say, first of all, are we concerned this individual is not going to come back for his follow-up? We're already going to need to see him because he has an elevated blood pressure, regardless of all the other stuff, is we're going to need to manage the blood pressure and get him back. Are we concerned he's going to be able to come back? 100%. He is potentially unhoused. He is having transportation issues. We are lucky we got him here today. This is an individual who is going to need some social collateral support and a referral to social services and community health worker. So my recommendation would be a CHW to start seeing him regularly using coaching style system twice a month to start working with him through available services and setting goals with him to use services and to get himself back on track in a variety of different areas, both in his medication adherence, his adherence to other things like the use of social services, and getting that coordination done so that he can actually do his colorectal cancer screening, be if it's fecal, blood, or colonoscopy. So this individual will need a lot of support, a lot of support. And that's the strength of the interdisciplinary system, right? We're not just nurses, we're not just physicians, we're not just case managers or folks at the front desk. We work together in patient care. No one owns the patient care. We all work together. And these are the kinds of patients where that really makes a difference because a lot of things are going to be need to be coordinated here. And some folks will say, well, why can't the patient just get this stuff figured out themselves? Shouldn't he have done this already? These real things that real people say. It is unreasonable to expect someone like Mr. Rossi to be able to pull this together. When you are dealing with unemployment, when you are dealing with unemployment benefits running out, when you are dealing with homelessness and a whole host of chronic medical issues, those are all full-time jobs. The CHW based support is what can make the difference. Strategic support in strategic areas, so Mr. Rossi or Mr. Thomas, whatever you prefer, is able to get his life back on track in a medical compliance perspective. And to continue to make his life better in other ways as well. He's not that old. He's 57 years old. He could have a long working history ahead of him and could stabilize his life in a lot of different ways. This is an inflection point for him. Is he going to go down one road or the other? And the support he gets is really what's going to be the determining factor here. Yeah, food insecurity is a big one. And I'll say with food insecurity, I've never been hungry before, like in a long term, like for the day maybe, but like I've never experienced hunger. I've worked in other countries. I spent years living in Haiti when working with people who are really experiencing like famine, and it deeply affects how you think and how you act in your environment. It really makes everything moment to moment because you're thinking about that next meal. And for someone who is homeless and he's not getting good food, is it's unreasonable to expect him to be just from a mental capacity perspective to be able to organize all this stuff. Brain literally doesn't have access to enough glucose to think about it. Yes, 100%. And food security is one of the things that we can fix in some ways pretty quickly through food banks and local resources. So a good place to start. 100%. Next slide, please. How can we stop this guy from being lost to follow-up? You're going to see a lot of these patients. What are some high yield things we can do to make sure he's not lost to follow-up? What do you think, Fide?
The first thing that comes to my head is just the constant communication with the community health worker.
Mm-hmm.
I think that's just like a key aspect to if the community health worker is able to have like a or build like a trust and close relationship with the patient, maybe he or she is able to just, you know, be in communication with Mr. Rosie more.
Yeah, reminders every 2 weeks, right?
Yeah. Yeah.
100%. Reminders. Keeps it at the forefront of his mind, and each of those calls with the community health worker is a potential for education as well. So you won't need to pull teeth to get him to do something. He will understand and can self-motivate more than before. Uh,
Mhm.
so 100%. The biggest thing that just thinking of is his social needs questionnaire, non-medical needs. Yeah, trust. Okay, I like trust. I like that word.
Mhm.
Ask Fide. I've been stopping sessions whenever I see the word trust. Lizette, join us and tell me why I should care about if this guy trusts me or not. Why should I care? It's just important that he does things. Why is trust important?
Hello. Yeah, trust is important because oftentimes there might be resistance because they're trying to see if they can, you will help them, if they can trust you. And so, in my experience, just giving them that space to, I get to trust you by helping them with other social determinants of health, whether that might be transport, food, helping them with an appointment or with a referral with, somewhere else, something else that they may need in the moment, just helps them to stay in communication with you. Um, and hopefully come back to that conversation about the screening or another follow-up that's very important.
Lizette, who do you serve and how do you serve them? I think I have some guesses, but I want to hear it from you.
Yeah, so I'm a social worker at Alivio Medical Center in Chicago.
Fabulous. I really like that you use that term. It's being used more and more in the field. And I'll say this. A lot of patients don't have any trust of the medical system. And sometimes that's why they're not showing up. And in particular, when we're looking at people or groups of people who have been marginalized from medicine or by medicine over the years, and I think the rest of that goes without saying, there are a lot of reasons for folks to not have that trust. The onus is on us to build it. And I like what you said, Lizette, because you build trust by the old-fashioned way, by following through.
Right.
So starting with something like food security, with housing and so forth, with good communication and kind communication can help to build trust for an individual like this who may have had a bad experience with the medical system. Now, if he had a bad experience with the medical system and he comes in for the first time for a while, and the first thing he hears is cancer, that's a tough one. Building the trust is necessary to get him to treatment. Thank you for sharing that, and thanks for serving who you serve, how you serve them. So, yeah, 100%. And if I was going to build some trust with him, I'd start with his food and I'd start with his transportation too. Diana, please, you've got something to say? We'd love to hear it.
Yes, can you hear me?
Yes, ma'am.
Thank you. Yeah, I was just gonna say also like not making them feel like overwhelmed, as Lisette stated, and I was gonna comment that too, taking one issue at a time. I feel, like starting with like food insecurity to get get them, those nutrients and just in better health, making sure the medication is being taken and things like that. But I've noticed, like, and with the population that I serve here, there's a lot of elderly people, and they get tired. They're tired, and they just, feel like it's too much if you bombard them with, oh, here's this, here's that, So, like, what I do is I just, focus on one thing. Like, okay, here's a bunch of food pantries where you can go. Here's the address. Here's the phone number. Do you need more information about it? Would you like to call together? Things like that. That's what I'm doing. Um, so I just wanted to mention that I'm with Marana Health in Tucson, Arizona.
Fabulous. Are you a social worker as well, Diana?
I'm a community health worker.
Fabulous. Fabulous. I think you're both 100% right, and there's a lot of overlap between these two linked professions, and you all are doing a lot of coaching with the patients and longitudinal conversations with them in a way that I can't, right? And to be frank, and I'm not sure if this is obvious, I don't have the social tact to do a lot of that either. Because that is a skill that you build through professional history of working with people with non-medical needs, and it is a very difficult skill to develop. So good on all of you for having that and for doing that, and I appreciate that. That being said, the longitudinal connection that you're able to make with patients over months, in some cases, is powerful and gives you the ability to do that. I agree with your approach, being able to break things down over time. And that also connects to what your colleague just mentioned, because if you're able to take things and give them put them in front of the patient in a way that they can digest. And because what happens if you eat too much and you can't digest? You vomit, right? I think our brains do that sometimes too. I know mine does. Uh, if you break things down for the patient so that they can do it piece by piece and they can get results from what you are saying, from what the resources you are providing, that builds trust too. It creates a feedback loop. And that strengthens everything, not just what you're working on. Because if you can follow through on something, the next time you talk, they're going to have that positive experience, even if they don't think of it consciously. I'd say with this patient, I really want to get that transportation issue figured out too. Be it voucher, public transportation, what have you. That's the thing that I'm really concerned about. Want them to show up. Next slide, please. Now this is a literature review on community guide. Community health workers to increase cancer screening. What it did is it looked at community health workers and it looked at specific things they do, and evaluated them from a scientific perspective, broke them down, and showed what worked and what didn't. I would say it used the term community health workers and looked at folks who were community health workers. A lot of this applies to both social workers or case managers. Really depends on what the specifics of your job. So I just want to add that. So some key things here. One is the ROI on this. Engaging CHWs to increase cervical. This looked at cervical and colorectal cancer. Cervical and colorectal cancer screenings is cost effective on the basis of estimated incremental cost effectiveness ratios, basically the return on investment. In addition, quality adjusted life years saved from colorectal cancer screening with colonoscopy were associated with net healthcare cost savings. What does that mean? Folks, when we have case managers, CHWs working with these folks, not only does it get folks to get their screening, but it saves the system money too. To the point where it is worth paying for these individuals to do this job. FYI. And I put that in there because a lot of folks in the non-medical needs area, as budget cuts kind of happen, get worried sometimes. Pull out this publication and put it on your supervisor's desk. It shows that if you are CHW, that yeah. You save the money, the FQHC money, you save the system money, and you help the patients at the same time. Those cost savings aren't always obvious to folks that oversee these positions, the executives and so forth, because they may not be aware of this research. Here's a quiver for an arrow for your quiver. Next slide, please. Well, we're going to breeze through this. I'm not going to go too much into the percentages. But essentially, CHWs, putting CHW on the case increases colorectal cancer rates by 10.5% over populations. Next slide, please. Another cool study for you to print out and read with your friends. Have some coffee. I'm an espresso person myself. Read it with your colleagues. Read it and like make it a book club. Like, why don't we book club research more often? It makes us better and more informed. Do it with your colleagues. It's fun. I do it. It's a good way to learn things and to stay up at the top of your field. It makes you sound smarter because you understand what's going on. You can cite these things to patients and to colleagues. Something I recommend doing is a good way to push yourself forward professionally and make your patient care better. So the sort of the things that CHWs do here, this is what the research broke them down into. The mediation among communities and individuals. Two, providing the patient education. Three, the care coordination itself, like getting the resource, linking someone to the resourcing. Four, the coaching. That's not just teaching someone, but motivating them around data. Five, the educating of individuals and communities on public health issues. And six, the building individual and community capacity. That's linking the resources and building infrastructure. If you have different services that are in different nonprofits or different organizations in a community, and you put a CHW in there and they start, or a caseworker in there, or a social worker in there, and they start linking people to things, well, now you have infrastructure. These individuals are integral parts of social infrastructure. So these are all the different things that the research actually looks at and evaluates. All of them drive cancer screening in different ways. Next slide, please. I'm not going to be able to go through all of them, but I will give a sort of a Cliff Notes version of it. Next slide, please. See, I was worried I wouldn't have enough FIDE. Now, I think if I've got 2 minutes, the thing that I want to focus on is really so think of all these different services we're doing. Mediation, public health education, care coordination, coaching. I put them all here because they work and they're validated scientifically. If you don't trust me, look at the paper. If I want to give you one thing to take home with about this is the importance of doing all of these longitudinally and documenting them. When you see an individual, always take the opportunity to provide public education when you can. Do it every session you have with someone, even if it's something run related. Take the opportunity to raise their capacity. It is scaffolding for success. Two, make sure that is consistent. That helps build infrastructure in the patient themselves so that they understand what's going on in their bodies and they can self-motivate. Now, and the other part is the coaching aspect of it. People do well with coaches because they motivate them. A good coach motivates you. And when you're working longitudinally with the patient, being able to find their areas of success now, encourage them around that success, and to help them to build similar success in other areas. If they say are compliant with their medication now, tell them how awesome that is. Let's get you compliant about some other stuff. See how good that feels? Let's feel about other stuff too. And yes, we will email this stuff. I think FIDE will actually. Let's transition to FIDE. She'll tell you how you can email things. I think I'm out of time. Thank you.
Thank you. That was a good transition. Thanks everyone, and thank you so much, Kevin. This was a wonderful webinar series with all the great information you shared with everyone. And I appreciate also the participation of everyone as well during these 2 sessions. So You will be receiving all the content, the slides, the recording, and the link to our website where you can have access to everything on our follow-up email. And then just as a reminder to please complete our post-evaluation. Please let us know your thoughts on how we can also improve in our future sessions. And if you are also interested in any future topics that you would like for us to present on. This is just a quick disclaimer that the content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA for the U.S. government. Again, thanks everybody, and here is our direct contact information. If you have any follow-up comments or questions, you may also contact us here. Have a wonderful rest of your day, and I hope you guys have a wonderful summer as well. We'll see you next time.